not to be confused with runner's knee, which often affects runners, or Sinding-Larsen and Johansson syndrome and Osgood-Schlatter disease, which primarily affect young athletes. Patellar tendinitis is a relatively common cause of pain in the inferior patellar region in athletes. It is common with frequent jumping, and studies have shown it may be associated with stiff ankle movement and ankle sprains. Presentation: jumper's knee commonly occurs in athletes who are involved in jumping sports such as basketball and volleyball. Patients report anterior knee pain, often with an aching quality. The symptom onset is insidious. Rarely is a discrete injury described. Usually, involvement is infrapatellar at or near the infrapatellar pole, but it may also be suprapatellar. Depending on the duration of symptoms, jumper's knee can be classified into one of 4 stages, as follows: Stage 1 pain only after activity, without functional impairment. Stage 2 pain during and after activity, although the patient is still able to perform satisfactorily in his or her sport. Stage 3 prolonged pain during and after activity, with increasing difficulty in performing at a satisfactory level. Stage 4 complete tendon tear requiring surgical repair. It begins as inflammation in the patellar tendon where it attaches to the patella and may progress by tearing or degenerating the tendon. Patients present with an ache over the patellar tendon. Most patients are between 10 and 16 years old. Magnetic resonance imaging can reveal edema in the proximal aspect of the patellar tendon. Causes: it is an overuse injury from repetitive overloading of the extensor mechanism of the knee. The micro tears exceed the body's healing mechanism unless the activity is stopped. Among the risk factors for patellar tendonitis are low ankle dorsiflexion, weak gluteal muscles, and muscle tightness, particularly in the calves, quadriceps muscle, and hamstrings. The injury occurs to athletes in many sports. Treatment: early stages may be treated conservatively using the RICE methods. Rest, ice, compression, elevation, exercises involving eccentric muscle contractions of the quadriceps on a decline board are strongly supported by extant literature. A physical therapist may also recommend specific exercises and stretches to strengthen the muscles and tendons. Should this fail, autologous blood injection, or platelet-rich plasma injection may be performed and is typically successful, though not as successful as high-volume saline injection. Uncommonly it may require surgery to remove myxoid degeneration in the tendon. This is reserved for patients with debilitating pain for 6–12 months despite conservative measures. Novel treatment modalities targeting the abnormal blood vessel growth which occurs in the condition are currently being investigated. See also: patellar tendon rupture, tendinitis, tendinosis, repetitive strain injury. References. Further reading: Kaplan, Helms, Dassault, Anderson, and Major Musculoskeletal MRI 2001. Khan K.M., Boner F., Desmond P.M., A.L. Patellar tendinosis, findings at histopathologic examination, U.S., and Mr. Imaging. Victorian Institute of Sport Tendon Study Group. Radiology 200, 821 7 doi, 10.1148/radiology. 200.3.8756939. PMID 8756939. Khatun J.A., Kvist M., Alanin E., Kwajala U.M. Long-term prognosis for jumper's knee in male athletes. A prospective follow-up study. Amj Sports Med 30, 689 €92. PMID 12,239,003. Tom Crisp, Faisal Khan, Napadia. AL high-volume ultrasound-guided injections at the interface between the patellar tendon and Hoffa's body are effective in chronic patellar tendinopathy, a pilot study. Disability and rehabilitation. 30, 1625 €34 doi, 10.1080/09638280701830936. PMID 18,608,403. External links: Jumper's knee in acrobatics, patellar tendonitis, musculoskeletal consumer review. ultrasound images demonstrating patellar tendinosis and an autologous blood injection.